Good morning, everyone, and welcome to the second webinar in our series of 4 that we're delighted to be hosting with Welby Assist. This morning we welcome our Head of Payroll, Damon, Tunnicliffe, who specialises in staff NHS pensions and payroll. He's going to be giving an update on pension and payroll legislation this morning. We will then be welcoming Chris Jarvis from Welby Assist, who will be covering the second WE statement, which is caring and responsive. If anyone has any questions, please do pop them in the question and answers chat, and we'll answer these at the end of each session. There will also be a feedback form coming out, so do put any questions on there if you haven't put them in the Q&A screen. So Damon, welcome, and I'll pass to you.
Thanks, Kay. Good morning, everybody. I'm delighted to be able to give you an update today on NHS pensions and payroll updates. I'm just going to share my screen for my presentation. Great stuff. I'm actually going to start the presentation with some good news. I think sometimes we talk about pensions and payrolls, and it's that dread of what's going to be coming out and what's going to be changing. So NHS pensions have confirmed on the completion of the annual SD55 year-end submissions that there is again no requirement to include mid-year contribution rate changes. It is just the contribution rate at the end of the year. So i.e. whatever percentage the employee is in March 2024, that is all that you need to put on the SD55 annual update. And if you are like me and you administer those NHS pensions annual updates, you will be absolutely delighted with how much time that will save. So I thought I'd just kick off with some good news that has been confirmed. Touching on employer contributions, and there's some more good news there as well, as that percentage is increasing as well. But it's not impacting on you as the employer or organisation. That part is fully remaining at 14.38%. However, the central payments made up by NHS England have increased to 9.4%. So an overall increase to an employer pension of 3.1%, meaning that the total now is 23.78%, which includes the 0.08% admin charge. So going into employees' pension pots is 23.7%, up from 20.6%. So and I'll come on to payroll update, but so as times are getting hard and employers are feeling that pinch with potential pay rises, they are getting 3.1% into the employer pension pot coming from NHS England. Looking at employee contributions now, and the second phase has now been confirmed. These are going to be coming live from the 1st of April 2024. As you can see from the slide, the tiering now is getting condensed. Before it was there was 11 tiers potentially that an employee could be at, but now that is getting condensed into 6 tiers, as I showed on the screen. So basically, what does that mean? It means that there's less changes for those employees who were probably between the 6.1% and 9.8% band. That was a very tight banding where with any additional hours, people could be fluctuating up and down quite a lot, which resulted in fluctuating their pay. So by now having a bit more of a stable table and a bigger banding gaps, they should see that they're not moving up and down tiers so much. It also still means though that obviously the assessments have to be done each month and based on the actual pensionable pay from the month before. If you're currently not doing those assessments and we're not doing your payroll, please check with your provider that your provider is doing those assessments. I found a couple of providers that haven't been doing those assessments, which would then effectively impact on actually the pensioning tiering contribution. So please just check with your provider that they are making the correct tiering assessments, and they're going to be based now on the new tiers going forward from the 1st of April 2024. Other changes that are going to be effective from the 1st of April, and this one is quite relevant really. So any overtime that is pensionable for part-time workers, except where a member has recently taken partial retirement, will not become pensionable. So if people have taken partial retirement, they are part-time, their additional hours will not become pensionable. Whereas if they have not taken partial retirement, it remains the same, that the additional hours are pensionable up until the full-time equivalent. What does that really mean? So then in the previous 12 months, if they have taken partial retirement, you need to be letting your payroll provider or know from the 1st of April that employees have taken that. So anybody from the 1st of April taking partial retirement, please do let your provider know, or if you're processing your own payroll, please just make a note that that pensionable, that extra additional hours or overtime, however you decide to call it, is not going to be pensionable. It's just something else that needs to be tracked and another admin task. So I think they really are the key highlights of the pension. SD55 annual updates pretty much the same as it was last year, less admin work, so an absolute great plus. Employer contribution increasing by 3.1%, but that is from the central pot, and employer contribution still remains at 14.38% from the employers. The new tiers, as I'm discussing, as I've displayed on the screen, basically hopefully less fluctuation for employees, for those, especially for those part-time employees that work additional hours, and potentially might work more additional hours. Some things potentially around flu clinics and things like that, where they would see their pay quite fluctuate, and that if anybody then is taking partial retirement from the 1st of April, that for the next 12 months, that any additional hours that they work won't become pensionable. So that moves us on to the payroll legislation. So I'm going to be talking about payroll thresholds, rates and codes, national insurance thresholds and rates, national minimum wage, which is a big hot topic at the moment, statutory rates, and student loan and postgraduate loans. What I would say, everything that I'm going to go through today in this presentation is legislation that I've seen is coming out from the new tax year, from the 6th of April 2024. I will caveat that with, though, there is a budget next week, and who knows what potentially could be changed. I would very think that a lot of the legislation won't change that they've already discussed, but I just have to warn you that just because I've said something today, it potentially could change next week, but highly unlikely. But I just want to caveat that there now. So just looking at the pay-as-you-earn thresholds, rates and codes to start with, that they are remaining as they were last year. So personal allowance for everybody, or for everybody, starts again at £12,570. So ultimately, what does that mean? That the 40% banding, you start paying 40% tax, starts from £37,701. But if you add your personal allowance on top of that, of the 12,570, in reality, you need a salary of £50,271 before you're paying that 40% tax band. But in terms of then NHS pensions, because NHS pension is deducted before tax, and looking at the new table between the with the bandings, if your salary is roughly around £56,000 or above, then that will see you into the 40% band. But if anybody below 46, you'd remain at the 20%. So I've looked at the new pension rates and also that the tax rates remaining the same. Just to confirm, obviously, because we are starting to come to year ends with P60s being issued by either yourselves, providers, or us. Just to note that the figure on the taxable pay figure on the P60s is not the employee's salaries. It is the taxable pay, so it's gross pay minus pensionable pay equals taxable pay. So the P60 figure doesn't relate to effectively their salary. We see so many queries come through to say, why haven't I been paid my salary? You have, but the taxable pay is minus the pension. So just a reminder of those P60s coming out. National insurance thresholds, again, nice and easy. They remain the same for employees and employers. The employee primary threshold for a year is £12,570 or £1,048 per month before somebody pays national insurance. So again, if people are coming to you and say, look, why aren't I paying national insurance? They are not hitting the threshold of £1,048 per month. And that is at point of payment. So if anybody above that will start to pay national insurance, and the rate of 10% for employees will continue, which was changed in January. So again, we're seeing a slight bit of money back to employees. So that at the moment is remaining at 10%. From an employer point of view, in the secondary threshold, that remains the same. So anybody earning a salary over £9,100 or £758 per month, you, as an employer or organisation, will pay 13.8% over that £758 per month. I know a lot of our clients and a lot of practices are looking at budgets and for the new year. So just having those 13.8% employer and 14.38% employer pension just gives you a figure of what your costs are potentially going to be. So the one that probably we're getting most queries about at the moment, and rightly so, is about national minimum wage. I'm sure many have seen the national minimum wage range changes and looking at how to budget these and the impact of the employer costs on top of them. I've looked at how the percentage gap with practices, and it becomes increasingly difficult with also some income streams being cut. So a lot more important if we're doing your payroll as well, to provide certain particularly reports on a year-to-date basis, on a departmental basis, so you can keep potentially on top of those budgets, because they're going to be quite steep rises. So I'm going to have a look at now the main national minimum wage increases and the legislation around that. On my screen, you'll see I have displayed the new rates from there. And I'm just going to bring your attention firstly, probably not to the figure, just to start with, of 1144, but also but to the top band. And if you can see that the age now is going to become age 21 rather than 23 and over. So again, if you've got employees in that 21 and 22 band, that before were on £10.18, they're going to be moving to 11.44. So you even encompassing more people down into national minimum wage at a lower rate, and also then at probably at entry points that when people are starting with you as an organisation. You can see that so those employees that are age 21 or above is increasing to 11.44. That's increasing from £10.42. That those obviously will know that's a £1 and £1 and 2p increase, or a 9.8% banding, the highest for a long time. It's quite staggering. But if I've just touched on there, the age 21 and 22 that were originally on £10.18, they also increased to the 11.44, which is a £1.26 uplift, or a 12.4% increase. So again, very steep. Moving down the table, 18 to 20 year olds, they're increasing to £8.60 from £7.49. That is a 14.8% increase, or an increase of £1.11 per hour. And your 16 and 17 year olds or apprentices are seeing the highest percentage increase. They're increasing by 21.2%, increasing from £5.28 to £6.40. So lots to think about there, really, of cost and how you're budgeting, really, because they are very steep. Moving on to statutory rates. So your SMP, your adoption pay, your shared parental pay, your shared bereavement, your statutory parental bereavement pay, and also your paternity pay. And I've deliberately left paternity pay to the end because I just want to touch on something on that. So those rates are now increasing to £184.03 per week, from £172.48 after obviously the first 6 weeks at the higher rate. So an increase there, yeah, to £184.03 from £172.48. Parental leave or paternity pay, as well, deliberately leave to the end. So there is some employment law changes regarding paternity pay. So husband now are able to take their leave and pay at any point in the first year of birth, rather than in the first 8 weeks and consecutive. So before, legislation permitted fathers had to have 2 weeks. If they wanted the full 2 weeks, they had to have them consecutive, and they had to be in the first 8 weeks. That is now being split down, that they can have 2 blocks of 1 week, and they can stagger that throughout the first year of birth. So yeah, relevant to obviously men in your organisation, possibly to females as well, where it might be that they're going on maternity leave, and it might be something that for you to say to them, or has your partner or husband realised that that they're now eligible to be able to take this leave. So a really good thing that's now starting to come out, but the pay does remain the same on that parental pay, which is going to be the £184.03 going up. Statutory sick pay, that is also increasing. That is increasing to £116.75 per week. That increases from £109.40, so £7.35 basically per week. Just putting that down into a 5-day worker, if they were, you used to be looking at a £21.88 per day, or £23.35 now, as it is going to be. So a total of £116.75 per week. Just something else then, probably lastly, want to touch on, and that is student loan and postgraduate loans. The only plan type that is increasing is plan type 1. So before that plan type 1 is anybody that was student loan before 2012. Those rates were lower than plan type 2. So plan type 1, you had to earn a salary of £22,015, which equated to £1,834.58 before student loan was taken on a plan type 1. That's now increasing to £2,082.50 per month, or £24,990 per year. So another roughly £200 that employees on plan type 1 can earn before they're starting to repay that student loan back at 9% through the payroll. So if people of your employees are between that 1,834.58 bracket and the 2,082.50 band where they've been used to paying student loan, and all of a sudden from April they see it on their payslip saying, I haven't had student loan deducted, tell them not to panic. It's the threshold increasing, and only when they go over that threshold per month do they get student loan deducted from them. It is set up always in the background to then just take again when they exceed their earnings. But you plan to those on plan type 2s, they're frozen. They're for your employees that have come out of education or loan after 2012. So any new students out of university, that remains, and the threshold for that is £2,274.58 before they're paying back the 9% per month on that, and that equates to the £27,295. So you can see that it used to be about a £5,000 gap in between those student loan different plan types, and it's been cut to about £3,000 now. And then just the final thing, and I'll invite any questions that anybody's got at the end of this session, or again after Chris's, hand over to Chris. It's just around postgraduate loan, and that remains that if anyone has a postgraduate loan, they remain at £21,000, which is £1,750 per month, and 6% on that as a deduction rate. So at the minute, not too much in terms of payroll legislation in changes, but definitely the biggest takeaway at the moment is national minimum wage. So happy to take any questions if there's any, Kay, or hand over to Chris.
Yeah, there are. We've got a question coming saying or asking, when apprentices aged 21 have completed their first year, does this mean that in their second year they would move to £11.44 per hour?
Yes, absolutely. Yeah, it's quite, that's even it's a steeper jump now to that, but yes, that's correct. Good question.
The only question that we've got come through at the minute. So thank you, Damon, for that very informative update. Obviously, aside from drugs costs in dispensing practices, staffing costs are obviously your highest costs, so a really helpful update there. Just a reminder to everybody regarding the taxable pay that Damon mentioned, it's not the pensionable pay figure that is needed for the type 2 certificates. As Damon said, the taxable pay is after deduction of employee contributions. So as mentioned last week, if you were on the webinar last week, then do make sure that you give the salaried GPs their pensionable pay figure. And certainly if we do the payroll, Damon and the payroll team can provide that. Damon also mentioned that where employees are in the pension scheme for the full year, salaries of over 56,000 attract the higher rate of tax. So thank you very much, Damon. That's brilliant. I now have pleasure in welcoming Chris Jarvis. So for anyone who wasn't with us last week, Chris is a former CQC inspector and brings a wealth of expertise in the healthcare regulation and quality assurance, having dedicated 11 years to the CQC as an inspector. Chris has played a pivotal role in ensuring and evaluating the standards of care provided by healthcare organisations. His extensive experience as an ex-CQC inspector has equipped him with unique insights into the intricacies of compliance, allowing him to provide valuable perspectives on how organisations can meet and exceed regulatory expectations. And beyond his regulatory expertise, Chris is now dedicated to sharing his knowledge and insights with others, whether that's through mock inspections, staff education, or hosting webinars. Chris continues to contribute to the improvement of healthcare quality by empowering individuals and organisations with the information that they need to navigate the ever-evolving landscape of healthcare regulations. So we're very pleased to welcome Chris today, and I'll hand over to you. Thank you, Chris.
Thank you, Kate. Good morning, everybody. I trust people can see me. I'm just looking at the screen here. I can't see myself, but anyway. First of all, I'd like to recap on what I spoke about last week, for those people who weren't with us, about CQC organisation and the what's called the assessment process now, rather than inspection process. So the word inspection has been erased from the CQC mindset. It's all about assessment. So CQC is recently reorganised in as much as that instead of being 3 separate directorates, adult social care, hospitals and private medical services, they're all amalgamated into multidisciplinary teams, which in practice equates to maybe 8 or 10 inspectors from various disciplines, working as one under the management of one manager in a particular ICB area in Lincolnshire, which is what I'm most familiar with. That equates to 2 teams from health, hospitals, adult social care and private medical services. Going forward, at the moment, there are no assessments being scheduled to take place. Assessments are taking place, but they are purely on a risk basis. So if information concern comes into CQC, they will assess the veracity of the information they've got and make a decision as to whether they'll do an assessment. And that may be completed through asking for information from the provider, or include a site visit as well. And the idea going forward is that assessments will be more frequent than inspections were, and more relevant in assessing quality and providing more up-to-date ratings. The ratings are staying the same, so it's still got the 4 categories of outstanding, good, requires improvement and inadequate. The regulations are the same. There's been no change to the primary legislation, the Health and Social Care Act. The only change has been statutory instrument, which brings in powers for the CQC to investigate, to assess local authorities, which is obviously in terms of adult social care, which wasn't possible before. So the evidence you as providers are collecting is the same. It's up to you how you meet requirements of the regulations. All you need to do is meet the requirements. How you do it, and how you collect it, and how you store it, and what process you go through to get it is a matter for individual practices. So all you need to do, despite all the talk about we statements and evidence categories and all the rest of it, that is really just a process thing for CQC to go through. The evidence they'll be looking at is exactly the same. Okay, so I looked at the website. It was updated. The CQC website was actually updated superficially yesterday, 27th, and there's now a statement saying that the CQC were reviewing how well the new system is working right up until the end of June 24. So that's another, well, nearly 6 or 5 months, isn't it? At the end of that period, they'll decide on the frequency of assessments for each of the sectors, and the information regarding that, about what they're going to do, will be published in July of 24. There's been a lot of talk about how ratings are going to be decided and the process. I mean, I've looked at it for hours, and it is so complicated as to be unintelligible to my mind. I would urge you to go online, have a look at the CQC website about the new scoring system. It uses some algorithms, and it talks about assessing practice against the core standards. And if it scores from 4 to 1, so if you get 4, that's outstanding, 3 is good, 2 requires improvement, and 1 is inadequate. For each of the categories of inspection, of assessment looking at, they add them all up, divide them by the numbers they've looked at, and you get a score at the end of it, which tells you which rating, what rating you'll get. But it is, to my mind, it's very subjective, and personally, I can't see it being very effective. But that's the decision they've made. There is, at the end of all that, an opportunity for practices or providers to make representations against any decision they make, which is something, I suppose, and I think reading between the lines, you're urged to do that actually, as a means of. So that's that. Before we move any further, if there's any questions about the new assessment process, and I think I forgot to mention, I should mention actually, is that you no longer have practices no longer have a dedicated CQC inspector who's a relationship holder for your practice. That's all gone. There's no portfolios now. So basically, you've got nobody to contact. If you have any queries or issues or need to discuss something about your practice, about significant events or complaints, whatever, there's nobody to turn to at all. So you're pretty much on your own. So if there's anything, I'll take questions now, or at the end it matters not. So I can't see.
There's just we've got a comment that the scoring system is unintelligible to the mind of the person that made the comment. But no questions at the minute. Okay, that's fine. That's what I thought it was as well. Okay, so I'm just going to move on now. There'll be some more questions towards the end, I'm sure. So this morning, I had prepared to talk about responsive. I'm told it's caring. So we're going to talk about caring. Now, caring in the past, under the previous inspection process, it was always relatively difficult to get evidence and information about this is met the requirements to caring key question. We used to talk a lot about carers and support for carers and all that sort of thing. The quality statements now related to caring are a bit more specific, but having said that, they seem to me to be directed primarily at adult social care, and for instance, kindness, compassion and dignity, although it's obviously relative to primary medical services. Regulations that underpin that are actually Regulation 9, which is person-centred care, and Regulation 10, which is dignity to inspect. And in my 11 years working for the CQC, I can never recall ever using those two specific regulations in respect of treating people as individuals. According to CQC, the related regulations are, again, Regulation 9, person-centred care, dignity and respect, which is 10, and premises and equipment. Again, apart from Regulation 15, premises and equipment
I can never recall using those two regulations. Independence, choice and control is about promoting people's independence and know their rights and have choice and control over their own care, treatment, well-being, which seems to me very, very targeted at people living in care homes, nursing homes, and the like. So I'm not absolutely sure how that fits in with private medical services. Responding to people's immediate needs. So it's about listening to understand their people's needs and wishes and views. Again, there's only Regulation 12 really, which is about safe care and treatment, which seems to encompass it. But actually, receiving and acting on complaints is for the first time encompassed within the caring key question. It never used to be. In fact, under the new assessment process, a lot of stuff that you would have normally looked at has moved in different key questions. And a good example of that actually is about access to services, which always used to be part of the responsive key question. Well, that responsive key that has now moved into the safe and effective key questions out of responsive. So there's been some moving about. As far as the practice is concerned, that shouldn't make any difference. You do what you do. It's up to the inspector or the assessor, if they do it remotely, when they do an assessment, to fit it into the key question they think it fits in. So as far as practice is concerned, the evidence you need to collect is exactly the same. It's just it will appear in a different format in the subsequent report than it did before. It won't be where you would normally expect to see it, provided you've had inspections in the past and you've read them and you realise where those things are. So that's it. I mean, as before, caring is a really difficult one to provide or to document evidence for, because a lot of it is very subjective and what people think and feel, and so it is a little bit difficult. More easier in adult social care settings, but it's problematic in private medical services. And I'm just going to move very quickly on, to no time moving on to responsive. So again, this is about person-centered care again. So there's a crossover there into the caring key question. And then care provision, integrity and continuity. So that's about understanding diverse needs of people and local communities. And it's the movement between services, which is one of the focuses of assessment going forward. Providing information is another one. And that's about providing appropriate, accurate and up-to-date information in formats that you can tailor to individual needs. So this is also about meeting assessment information standard. I know most practices do that and have been required to since 2015, I think. But I mean, that's something that will be looked at, but it is now a fundamental statement that you have to do that. Before, it was sometimes skirted over a bit if practices weren't doing it or couldn't do it for various reasons, but there needs to be a rationale for why they're not doing it. Listening to and involving the people, so it's reacting to what people are telling you. And again, it's about dealing with complaints properly and effectively, and documenting the complaints process and the learning from them. In fact, so it's Reg 16 and 17. Reg 16 it is the regulation that talks about receiving active complaints, and Regulation 17 is something you see all the way through these key questions, and that's good governance. And if it doesn't fit any of the other regulations, very often it fits under, as a breach, it fits under Regulation 17, which is good governance. Equity and access. So the we statements, we we make sure that everyone can access the care, support and treatment they need when they need it. And again, it's the same thought, safe care and treatment, again, Regulation 17, which is good governance. And that's the end, I think, aren't we? Yeah, we are. Equality, equity in experience and outcomes, again, very, very similar. Very similar. Again, you note that Regulation 17 is there again. And planning for the future. So it's not about planning the future for the practice. It's about planning the future for people, patients, whether patients in this case, about important life changes. And so we are. That's it. I mean, it is. I'll say it seems a bit daunting and a bit complex, and it is. But it's a new way of doing it. And I'll say a lot of the evidence and the issues that we talked about would normally go in, different key questions in the whole inspection process. But it is what it is. I would urge you to actually, spend some time reading it, so your mind is clear about what is happening and the requirements. But just remember, I would urge you to remember that the legislation has not changed. The legislation is just the same. The requirements for meeting those regulations hasn't changed, and how you collect the information and how you present it hasn't changed. Okay, nobody is going to dictate a format in which you should supply the information, how you collect it, how you store it, whether it be paper, whether it's using AI, or whether it's whatever you're going to use, you use, and it's up to the CQC to unravel it. Okay. So, any questions? I know I've run through it.
Super, thank you very much, Chris. Yeah, we've got a couple of questions, one for you and one for Damon. So we'll do yours first.
Okay.
So we've got one question coming there that says, should we be collating our evidence by we statements rather than key lines of inquiry?
Well, key lines of inquiry don't exist anymore, so that's that. So yes, I would say the answer is yes, but come the end of June and July, when they're going to decide whether the process is working properly, may have some effect on that. I don't know. I haven't got a crystal ball nowadays. But I would say yes. What I would say is, and to everyone in the call, that you need to be aware that the days of having an inspection every 4, 5, 6, 7, 8 years is a thing of the past, and you can expect quite regular assessments, whether they be remote assessments or on-site visits assessments. And so what I would urge you to is to get your house in order, get your ducks in a row, and make sure you keep on top of the evidence you may be required to produce in support of the we statement.
Super, thank you, Chris. Has anybody got any more questions they want to put in the Q&A for Chris? Whilst you are thinking about that or popping them up, Damon, we've got one here for you. For an apprentice year 3, 19-year-olds, will they move up to £8.60 per hour?
They will, yes.
Yeah. Super, thank you. Okay, there's no more questions popped up. So just a reminder that there will be a feedback form. So if you haven't got your question up now and you think of anything after we've come off the call, then do pop them on those feedback forms. And also please do complete the feedback forms. It really helps us to know, what you find is useful. So next week on Tuesday the 5th, Chris is going to be covering the third we statement, effective. And our ESG lead and assurance director, Sally Hearn, will be speaking about environmental sustainability. So please do join us for that. That is practice specific, NHS specific. So please do join us for that as well.
Can I just ask Kay that the slide pack we just used, if we can send that out to the
yeah,
attendees,
absolutely.
that'd be helpful.
Yes. Yeah, we can do. I'll let you send those across, and then we'll sort out sending that out with a feedback form, which I think is what you did last week, isn't it? Well,
yeah. Okay.
Super. Lovely. Yeah. Super. Okay, thank you very much, everybody, and we'll look forward to seeing you next Tuesday then.
Thank you very much.
Take care.
Thank you,
Thank you. Bye.
Bye-bye.